Greetings, everyone. My name is Paula Coronel, and today I'm going to talk about the randomized trial of endoscopic or open vein graft harvesting for coronary artery bypass. First, the definition. The venous vein graft is the most common conduit for coronary artery bypass grafting. The influence of vein graft harvesting technique on long-term clinical outcomes has not been well characterized.
New York Presbyterian offers the full range of options for coronary artery bypass grafting.
A majority of coronary disease can actually be managed with medicines, and that's the primary treatment modality for every patient that gets diagnosed with coronary disease. You're going to be on medications, and hopefully you can avoid surgery or even avoid an angioplasty or a stent. If you're not a candidate for medical therapy or angioplasty, you have to go to the operating room.
In the complex cases, we often have detailed discussions about how best to manage the patients and what surgery is the best for the patient. Often patients have multiple different problems with the heart, including blockages of the coronary arteries as well as valvular problems or aortic aneurysm problems, and our number one goal is to get the patients through the surgery safely.
We individualize the approach depending on the patient's anatomy, what problems they have with the heart, and then their age, their comorbidities, etc. You're going to have arteries taken and veins taken from various parts of the body. That's your own tissue, and we're going to use it to reroute the blood around the blockages. Again, that operation takes 3 or 4 hours on average, and you spend the first couple of days in the intensive care unit. That's standard, and then you go to the step-down unit. Our length of stay after bypass surgery is about 5 days. The risk is substantially less than 1%, and the patients do very well, and it's an incredibly durable operation.
We have a huge focus on multiple arterial grafting, which we think will provide our patients better and longer lasting outcomes in the long term with better patency of the bypass grafts.
In the past, vein were used to perform most of the bypass, but now we have learned by clinical research that the failure rate of the venous vein graft is substantially like 50% at 10 years. And so we have started using artery instead of vein for coronary artery bypass. In the United States, less than 6% of the surgeons routinely use multiple arterial graftings.
The long-term survival of the patients is better. The long-term durability of the grafts is better. You have less need for interventions down the line. You have a lower rate of heart attack down the line. And you have a 20 to 25% improved survival even at 5 years, compared to patients who don't have multi-arterial grafting.
I think this is part of the role of an academic center. We do things that smaller center or less experienced surgeons are not willing to do.
A lot of that research has been done here at Weill Cornell by our researchers, by our surgeons. They've published heavily in these areas and are internationally recognized figures as experts in the field of coronary artery bypass surgery.
The most important, I think, is the connection with the team in the office and with the physician that are always there.
I think that the patients that are considering surgery here at New York Presbyterian Weill Cornell need to know that whichever surgeon they choose for whichever problem they have, they're going to get a complete commitment from the minute they walk in to the minute they walk out and beyond.
Applications in medicine. On this clinical trial, patients were randomly assigned to coronary artery bypass graft at 16 veterans of cardiac surgery centers to either open or endoscopic vein graft harvesting. The primary outcome was a composite of major adverse cardiac events, including death from any cause, non-fatal myocardial infarction, and repeat revascularization. Leg bone complications were also evaluated. The goal on this clinical trial was to evaluate endoscopic vein graft harvest compared with open vein graft harvest among patients undergoing coronary artery bypass grafting.
Heart bypass surgery creates a new route called a bypass for blood and oxygen to reach the heart. Heart bypass surgery begins with an incision in the chest, and the breastbone is cut, exposing the heart. Next, a portion of the saphenous vein, which is very large, is harvested from the inside of the leg. Pieces of this large vein are used to bypass the blocked coronary arteries. which are arteries that supply blood to the heart. The venous graft is sewn to the aorta, the main artery of the body, and to the affected coronary artery to bypass the blocked site. The internal mammary artery from the chest may also be used to bypass a clogged artery. Several arteries may be bypassed depending on the condition of the heart. After the graft is created, the breastbone and chest are closed.
Now I'm going to talk about the pros and cons on this clinical trial. On this clinical trial, among patients undergoing to coronary artery bypass graft, we did not find a significant difference between open vein graft harvesting and endoscopic vein graft harvesting in the risk of major effects on adverse cardiac events. The primary outcome, death, myocardial infarction, or repeat revascularization occurring 13.9% of endoscopic vein graft group versus 15.5% of the open vein graft group.
This study showed no difference in outcomes in terms of major adverse cardiovascular events in patients who had saphenous vein graft harvested endoscopically versus open in a randomized trial. It also showed that there was reduced risk of wound complications in the patients that had endoscopic harvesting. I think this trial opens the question for further investigation, a larger study, more patients of diverse, not only gender, as this study was largely male, but also a larger group of patients with multiple comorbidities who may have had multi-vessel disease. So I think it opens the question for further study. Any longer-term follow-up we could have would be beneficial. In addition, data on patency would also be very helpful. The use of one arterial conduit is now a quality measure and is mandated, and that data is publicly reported for surgeons. So we know that the use of the left internal mammary artery to the left anterior descending should be done in all patients, if possible, undergoing coronary artery bypass grafting. And there are a lot of data now that suggests arterial grafting is beneficial to survival and for patency over the long term. So the longer term data that we would have, the more information we would know. However, vein grafts will always be in our armamentarium if arterial grafts are insufficient or inadequate, or for example, do not provide adequate flow in an emergency situation. So we will always want to know, would it be better to harvest it open or endoscopic or with small bridging incisions? Different surgeons are driven by different motivational factors. Time is one of them, whether or not they believe the data, the literature, and that arterial grafting provides prolonged survival and better patency compared to vein grafting. Also, many of us work at teaching institutions, and doing all arterial grafting takes a little bit more time and is technically a little bit more challenging and may be more difficult to teach in contrast to a vein graft.
This issue applies in our country, Ecuador. In medicine. Cardiovascular disease contributes to 24% of mortality in 2016 in Ecuador, using the Mortality National Registry in Ecuador. The myocardial infarction mortality rate increased from 51 in 2012 to 157 in 2016 deaths per 100,000, 16, and mortality due to ischemia to heart disease increased in Ecuador in the period from 2001 and 2016. No. Now, in conclusion, we have that endoscopic vein harvest reduces leg 1 complications compared with open vein harvest without compromising the 6-month patency rate. The overall patency rate depends on the target and vein-related values on the patient characteristics rather than the method of vein harvesting. Thank you.